One of the most tragic facts about pancreatic cancer is that it's often called, and correctly called, a silent killer. Not because it's rare, no, but because it hides in a plain sight. By the time it shows symptoms, it's usually already advanced and incurable. Let's explore why this happens. Pancreatic cancer, particularly pancreatic ductal adenocarcinoma, PDAC, ductal adenocarcinoma, not the most common type, arises from the epithelial cells of the pancreatic ducts. What makes it so insidious? It is its biological behavior. It grows silently, invades early, and metastasizes before it's even clinically detectable. Here is the key fact. Pancreatic cancer can develop for up to even more, 10 years before diagnosis, but it typically remains asymptomatic during most of the time. Molecular studies shows a stepwise genetic progression from normal ductal epithelium to invasive carcinoma, known as a PAN-IN, pancreatic intraepithelial neoplasia sequence. It begins with changing so-called mutations in KRAS oncogene, followed by inactivation of tumor suppressor genes like CDK2A, famous P16, TP53, and SMAD4. By the time these mutations accumulate, the disease has often already spread to the liver or peritoneum. Clinically, the earliest signs are subtle: fatigue, anorexia, vague epigastric pain radiating to the back, or painless jaundice, when the tumor involves the head of the pancreas, the most common types. These non-specific symptoms often lead to delayed diagnosis. From a diagnostic standpoint, CA99 serves a tumor marker, though it's neither sensitive nor non-specific. Imaging modalities like contrast-enhanced computer tomography, MRI, and endoscopic ultrasound are essential for detection and staging. Unfortunately, only about 5-10%, maybe 20%, actually, I don't trust this number, of patients present with resectable disease in diagnosis. Treatment options challenging. Surgical resection, famous Whipple procedure, offers the only potential cure, but recurrence is common. Adjuvant chemotherapy with agents like gemcitabine and FOLFIRINOX improve survival, yet the 5-year survival remains below 10%. But here is the most interesting and hopeful aspect. Recent advances in molecular profiling and targeted therapy are changing the landscape, identifying BRCA mutations. Yes, famous BRCA mutations, or microsatellite instability, MCI, can help guide so-called personalized treatment, including PARP inhibitors, PARP inhibitors, and immunotherapy in selected patients. So the takeaway is this. Pancreatic cancer teaches us one of the most humbling lessons in medicine. The early molecular events can hide for years before clinical disease appears. As future doctors, my beloveds, your job is not only to treat, but to think ahead, to recognize risk factors, genetic predispositions, and subtle early signs before it's too late. How? Actually, no idea. That's how we turn the silent killer, with God, by the grace of God, into detectable one. Try. If you can, you will obtain your Nobel Prize. Congratulations.